All right, so on page 206. 206. Page 206, we're going to find that the patient has an FRS left at C5 on C6. Right. And the way that we're going to do the treatment is pretty simple. Well, you know what, in case you have to maneuver the camera around. Or maybe, Joel? Dr. Norman, sorry. I'm sorry, 30 lashes after, right?
Our success stories.
Yeah, there you go.
Met him as a young man of 18.
Never thought I'd be modeling.
How old are you now, Joe?
29.
20.
How does that make you?
I'm an old man.
Oh my God. So,
It's just a number.
that's right. That's what they say. That's what Mom always says. All right. So when we're going to treat the FRS to the left of C5-6, what's really the component? What's the big component motion that's missing here? If they're flexed, they can't do what? Extend. Beautiful. So I would recommend that you always start thinking like that with everything we're going to learn from here on out. Take the big component, all right? So, what I need to do is first find my location, okay? So I'm going to come off the occiput, find the first cervical spinous process, which is the cervical spinous process of which segment? C2, excellent. Then we drop down, C3, C4. So I'm actually walking down, finger after finger. C5, and that's my problem segment. But what I'm going to recommend you do, and what Dr. Greenman recommends that you do, is go down to the level of C6, supporting the articular pillar there. And this is where that concept of roll glide comes from. If I now extend Dr. Norman's neck to the level of my finger, which is always going to be the first localization when you're doing an FRS, by virtue of me stabilizing C6, C5 now has a place to come over and help to close. So C6 is going, as Dr. Makovsky would say, under the wave. Right? Would he say that? He would say that, right?
For sure.
Excellent. Very good. This is piped in, incidentally, to Canada, so we're just really trying to score the right kind of point. So now I have him localized. I have him localized. And now all I need to do now to help create the correction for the FRS is side bend him to the level and allow him slight rotation. And you can see in that pink video, so ever so clearly, the subtle motion of it. What am I not doing? Watch the video. I'm not doing this. Because now where am I side bending? T2, T3, something like that, right? So it's subtle motion. I create the extension moment, side bend, rotate. And I don't really even have to do the rotation so much, but we like to do that in the lower cervical spine because side bending is coupled with the rotation, correct? Yes, very good. So now what I can ask him to do is, through the use of what's called the cervical ocular reflex, meaning the muscles, as you've learned, in the cervical spine are very much influenced by eye movement and eye position, I can have him look down towards his left hip into the direction of where he was positionally fixated. So go ahead, look down into the left, hold, 1, 2, 3, 4, 5, relax. Relax for 3 seconds, as I've mentioned before, for that relaxation to kick in. and a further localization of extension, side bending, and right rotation. To help do what to the right facet? Help close it. And my position under C6 is causing the going under the wave mechanism. C5 can now roll over my finger that's stabilizing C6. Again, check.
So could you repeat the thing with the down and left looking occipital?
Yep, absolutely. I can either use the eyes, or I can have him gently, Joel, gently lift your head to the left and tuck your chin going down towards your left hip. Good. Oh. So I'm stimulating all the muscle fibers that are helping to bring him into FRS left. Relax. Now they relax. I wait for the relaxation to occur, and I can now take him into further extension, side bend, rotation to the right. Okay? So you can use the eyes, or you can actually use the resistance, the muscle action itself. Okay? Both will be suitable. Both will be fine to help your patient. Okay? And after that, what do we always do? We want to reassess. So if I take him into extension at that segment, my limitation of extension, side bending, rotation to the right is no longer there.
How many times will you go through that sequence of like the relax and find the movement again?
I find that muscle energy works best at least 3 times, but certainly no more than 5 times is often indicated. Yeah.
Repeat, which muscles are you contracting?
The muscles that we're contracting here are the ones that would flex, side bend, and rotate to the left. And in this particular situation, which muscle did we talk about at 8:37? Maybe it was 8:41, because that was like the 4th slide. The left, what? Anterior scaling. Right? Good. So there you go. All right? Now I'm going to show you how to do the ERS correction, so that then when we go on the table, I can take you from FRS to ERS. And then we would switch partners and do the same thing. Okay? So follow along. Next one is going to be for an ERS at C2-3. This one's a little bit of a trick to it, but I know that you're going to do just fine with it. Okay? So if we have an ERS to the left at C2-3, we have a problem with which facet? ERS left at C2-3. Left facet. It can't do what? Because it's stuck shut. Yep, stuck closed or shut. Okay. So the way that we can help to improve that is we're going to do the reach around from behind, essentially. So we're going to get on the C2 spinous process, come off the occiput, go down to C2. We're going to just move inferior till we get to the interspace of C2 spinous process and C3 spinous process. Okay? So now I'm right in the midline. What I'm now going to do, I'm just going to lay the spine on you. Don't get nervous. So what I'm going to do now is I'm on the midline, but now I'm going to reach across to the other side. See my finger down here? Okay. I'm going to hook on that interspace, and I'm now going to translate it to the left, which is causing what kind of side bending? Okay, so we're going to help to get stabilized at the segment by creating the side bending movement, all right? Because if I side bend right, what's happening on the left side? It's opening, it's gapping. I'm compressing on the right or closing on the right, I'm opening on the left, okay? Now all I have to do, remember it was an extension lesion, so how am I going to localize first, after that? Flex. Flex up to the segment. Exactly.
You do that after you hook?
Yeah, I do that after I've hooked. Yeah. So find the interspace, come over, do that little translation. Bring them up into a bit of flexion. This is also where you can rest the head of the patient on your chest or with a pillow, or if you're standing, you can do it on the belly. Okay? Let me do that because that's the least intrusive for you and for the patient. Here, do the little side bend, up. Now I'm at the level. If I were to bend all the way up here, am I localized to C2-3? No way. It's just a little bit, up there it is. Just side bend. And now I'm going to do the rotation. Okay. So Joe, what I'd like for you to do is look up and over your left shoulder
Eyes, what you said.
with your eyes. And rest. 2, 3 of rest. Further flexion, further side bend and rotation. Again with your eyes. 2, 3, 4, 5. Relax. 2, 3. Further flexion, side bend, rotation.
I'm sorry, where's he looking?
He's looking over his left shoulder.
Over his left.
So he's stimulating his extensors, side benders, and left rotators. Frank?
You're always looking over the positional diagnosis, like the side.
If you were doing it for the ERS and the cervical spine, yes.
How about the FRS?
For the FRS, you're still looking into. You're right. You're looking into the positional dysfunction. Yep. And I'll encourage you to find any way you can to remember it, because once you hear like, do I do this? Do I do that? Is this it? Is it? And the last thing that the patient wants to feel is you trying to figure out what you need to do. Get a clear understanding of what you're doing before you do it with your patient. It doesn't matter what you're doing. Modalities, I'll constantly go back because I don't use modalities a lot, and I'll look for my parameters. Safety first, patient first. Okay. Patient versus therapist. Therapist always loses, most cases. But document everything because you want to protect yourself. Okay. Now, what if I didn't want to use the eyes? I could hold to his head like this and just resist the motion going over his left shoulder. Go ahead, move your head over your left shoulder, look over your left shoulder. Again, that's perfectly fine, and that's actually what's shown in the Greenman text. But you can take that, you could always have your hand on the occiput supporting and just use the eyes. You'll get just as well effects. Benefits. All right? So that's the correction for the FRS. C1, C5 rolls over C6. 6 goes under the wave. Say that at least a couple more times. And then the correction for the ERS on the left, the C2-3. Same setup as last week. We'll get through all of these before 10 o'clock. I'm almost thinking before 9:45, and then we'll almost be right on time for thoracic spine. Feet of the patient facing this way. Therapist looking at the clock. I'm going to take you through each one of them.